Buen día, Brasil. Buen día, hermanos latinoamericanos en SOLACI 2016. Es un gran placer hoy presentar un caso de Watchman desde Columbia University Medical Center. I'm going to quickly introduce our team here. We have Dr. Bob Sommer and Dr. Susheel Kodali, our interventional cardiologist for this case. From the echo side, we have Dr. Han. In anesthesia, we have Eileen, and our angioplasty specialist, Osama and Mark. So we can go to the slides. Today we're going to present the 56-year-old woman, diabetic, current smoker, with the first episode of atrial fibrillation in June of 2013. On aspirin since then, since she had a low CHAT score. She has past medical history of Crohn's disease since 2003, that underwent multiple GI surgeries, and now with chronic rectal bleeding and anemia. November of 2014, she had a bowel resection complicated by peritonitis and abscess, and recurrent atrial fibrillation for which she was treated with amiodarone. And on September of last year, she had a Holter revealing atrial fibrillation with rapid ventricular response. Aspirin was continued at that time. Next slide. Yeah. She got a cardiac cath on February of 2016 showing normal coronary arteries, and unfortunately a stroke on April 7. That was treated successfully with TPA and complete resolution of symptoms, and an MRI showing right thalamic and hippocampal infarct, and found on atrial fibrillation, and she was started on warfarin. Her primary cardiologist recommends evaluation for left atrial appendage closure, given she's a poor candidate for long-term anticoagulation due to her chronic rectal bleeding with anemia. The stroke risk for this patient, she has a CHAT score of 3 and a CHAT VAS of 4 points, given her diabetes, prior TIA, and the sex category. Next. The bleeding risk score for the Hasbled, she had 3 points due to stroke, bleeding, and being on aspirin. Next. So as a summary, we are treating today a young woman with paroxysmal AFib, diabetic, and recent history of stroke, with active bleeding and anemia, deemed a poor candidate for chronic anticoagulation, with a CHAT score of 3, CHAT VAS of 4, and Hasbled of 3 points. So we're going to show some echo images, I think, right?
Yep. Thank you very much, Juan. Thank you all for having us in your auditorium today. We're going to start out, Dr. Rebecca Hahn is going to review the echo images with her beautiful transesophageal scan.
Let me just introduce
the first thing.
Becky, hold on just 1 second. I just want to introduce the team so that you all know. So that was Bob Sommer, who is actually trained as a pediatrician and a pediatric interventional cardiologist, who's part of our group and who is really an expert in adult congenital heart disease, and he leads the left atrial appendage closure program. Next to him is Susheel Kodali, who's the director of our Structural and Valve Center at Columbia, and the presenter was Juan Terra, and Juan is originally from Argentina and has been with us. He did some training at Mount Sinai, is now a structural valve fellow, and of course Rebecca Hahn, who is going to be showing the echo, is our director of invasive echocardiography, and she will describe the findings, and I think you all met her several years ago when she came here and has collaborated beautifully with our Brazilian colleagues. So it's great to have you at SOLACI. It's a little bit cloudy and cold in Rio, which is very atypical. The weather is better in New York than Rio, but the traffic in Rio is worse than New York. So it's, a little
Marty, it was 55 this morning. It was 55 this morning. It's very cold.
Well, it was 50 in Rio.
Oh, okay. All right.
You win.
So welcome.
All right, let's show some pictures.
Okay, show some pictures.
So the first step on the echo imaging is to just confirm that there's no other concomitant disease. You can see here a normal ventricular size and function, normal function of the mitral valve, the function of the aortic valve also completely normal, and then on to assessment of the left atrial appendage. You can see here that we start at 0 degrees, and then move on to measurements. Again, the max diameter is a 1.85 at 1.9, but the similar length. You can use biplane, which kind of shortcuts the various dimensions that we have to measure, but we're usually pretty rigorous about going around 0, 45 degrees, and measuring at each different imaging plane, and then obviously 90 degrees similarly. And then finally, our largest plane tends to be at the 135 degree view. And you can see that with a typical windsock, it's actually a fan-shaped structure, and so the 135 view around there tends to give us our widest dimension, and indeed it could be as large as 1.5, but if we seat the device a little deeper, it gets to be a little bit smaller, and again, we can get an equal width and depth, again, if it's seated relatively well into the appendage. So you saw that the maximum dimension there, again, is a 24 to 25, but with a similar length of 24. Again, seated well into the appendage. You can see on three-dimensional imaging that it's a very oval-shaped, elliptical, and dynamic atrial appendage. This is a patient still in sinus rhythm. So we do tend to see a lot of dynamism in the orifice area. This is at its maximum on 3D, confirming that where we want to seat the device, which is, again, below the coronary artery, and well into the appendage, body of the appendage, you'll get a diameter of 2.5 centimeters. Again, marked dynamism with this particular appendage. We then get a full volume.
And
this
that's
is a little
in part, Becky, because she's in sinus rhythm, right?
Yes. And so with the full volume, and this is a little bit gained out in order to just look at the interatrial septum, we want to, this is tricuspid valve, this is your bicaval view here. And so looking at the atrial appendage over here, we want to aim for a septal puncture, transseptal puncture around this site. And toward that end, Bob then has already done the transseptal puncture. You can see here the location of it well above any other structures and free of pulmonary veins, etc. And
you want to talk about the importance of location, Bob?
Becky just mentioned it. I think this is a procedure where you need to get your delivery catheter as coaxial to the orifice of the appendage as possible. And so getting as inferior and as posterior as possible on the transseptal usually gives you the best shot into the mouth of the appendage.
And this 3D image shows well the trajectory, and in terms of doing that, the question, some people are starting to do this procedure with ice, or a lot of people, and can you get this level, I mean, from your perspective, early experience versus late, ice versus TE? Or?
Yeah, well, we haven't done a lot of ice for this yet. I think down the road, we're going to have markedly improved 3D ice catheters, which is going to give us a much wider sector, and that will really be helpful. Currently, we're still doing this procedure with general anesthesia and transesophageal echo guidance.
So this is just the 3D after the puncture, and the site, I think, is pretty ideal. The wire right now is parked in the lower left pulmonary vein, but the appendage is over here. And so, again, this should be a fairly direct shot into the appendage. And I think we're pretty much ready to go. This is Bob's catheter placed at the orifice.
Let me show just a couple. Switch over to the angiogram images, please. So here you can see this is the position after the transseptal puncture. And then we advance a wire into the left upper pulmonary vein and advance the catheter delivery sheath over the wire into the left atrium. That's just to get the maximum support. You don't really want to be pushing wires, particularly stiff ones, in the appendage. Once we're in the left upper pulmonary vein and have transited the septum with the large sheath, we'll pass a soft pigtail, usually an angled pigtail, pull back into the left atrium, and then manipulate, often under echo guidance, the pigtail catheter into the most anterior portion of the appendage. And you can see on this injection that we did previously, you can see the anatomy of the appendage, you can see the fan shape, but you can also appreciate that the catheter is not in the most anterior portion of the appendage, which is a little bit superior on this image. So what we did in this case was we advanced the sheath up to give us a little more support with to angle the pigtail in a different direction. And then we did a follow-up picture. Hang on.
You can see the sheath being advanced
Here's
here.
the sheath coming forward.
Very fastly, very quickly.
Right, and then we're able to get a different angle of approach, and now we're in that most anterior portion. You can see here on the injection. And that's currently where we are. And so we're going to move forward. We have, based on the dynamic nature of the appendage and on the oval shape of the appendage, with a maximum dimension of 25 millimeters on Becky's echo, which is really mostly what we depend on, we're going to use a 30 millimeter Watchman device for this case. Okay, so let's go live now. Here's the...
So we're fortunate to have
go ahead.
Carlo Pedra here, who has a lot of expertise, and hopefully he can make some comments and share some of his own experiences.
Hi, Bob. Hi, good morning. Hi, this is Carlos. Bob,
Can't hear.
2 questions. Do you usually use this projection, caudal projection, to profile the appendage? In Brazil, we are more familiar with the ACP device. We are just starting with the Watchman device. And in order to profile the neck of the appendage better, we usually go cranial, RAO cranial. And as far as I understand with the Watchman device, usually 135 degrees on echo and going caudal on angel, it's better. So would you like to make any comments
that's where we are.
With that?
Yeah, we try, you know, the 135 view is the one that gives us typically the widest orifice and the shallowest depth. So that's the one where we want to make sure where the device is seated optimally. So that's the view typically that we use for angiography, where we're doing RAO and caudal angulation. But of course it's variable from patient to patient, as you pointed out.
If you got a CT in advance, you could probably get these views and sort of look at that as well.
Do you take measurements on angio as well and try to correlate with the echo measurements? And how accurate is that? And do you rely on your echo measurements or angio, or both, give or take?
We're mostly using the echo measurements because, as a rule, they've been more accurate, but we use the fluoro images as a confirmation.
Also, one other point in terms of the measurements, we checked left atrial pressure when we got in, because if the left atrial pressure is low, you want to make sure they're adequately hydrated, because the appendage is a very dynamic structure and based on volume can change size.
Okay, so you can see that we've advanced the guide sheath over the pigtail. So the pigtail is protecting us from perforating this very thin-walled structure. We have an idea of where the ostium is based on previous angiograms, which we're looking at, but you can't see. And so if you look at the 3 distal markers on the delivery catheter, we want the first one is the depth needed for a 21 millimeter device. The second is for a 27 millimeter device. And the most proximal one is for the 30 millimeter device. So we want, for the 33 millimeter device. So we're going to want to get just between those 2 proximal markers at the level of the ostium. And so I've gotten the catheter almost to that point right now, so we're going to repeat the angiogram now, just to confirm our position. Okay, good.
Close, right?
Yeah, we're very close. We don't have a lot of extra room here to advance the sheath. You don't want to be tenting the tissue of the appendage. Again, it's a very friable structure, but I think we're just about there. So we can...
Yeah, I agree. I think it looks okay.
It looks pretty good. So now we're going to do, when we set up the... this is the device, which has already been loaded into its delivery catheter. I don't know if you can focus in on that. And you can cheat a little bit by advancing the feet out a little bit further to get an extra millimeter or two. Can you guys zoom in on that? There we go. So you can see there's a marker right here on the catheter, and you can see that the feet of the device are just a millimeter or so past that point. Pull it back now. Those are the feet sticking out the end of the catheter. Just pull it back, just like that. That gives us that 1 extra millimeter that we're going to need to get the device deep enough into the appendage. Okay, now
change orientation as you let go, huh?
Yeah, so when you let go of the catheter, there's a lot of torque on the catheter. So we have to maintain that anterior position. So we're just holding some torque on this. We're going to do another picture here because we may have changed position slightly. No, okay, we're good.
Looks good. Okay. Can you flush one more time?
It's a little bit hard to see the os on FOSS in this view.
Yeah, I know. Unfortunately, there's no way for us to demonstrate it particularly well. We have a very old school technique of marking the distal part of the appendage and the ostium of the appendage with a marking pen on the screen. But more than that, we have Becky to help guide us.
Yeah, so this is the 3D location of the catheter, and you can see it's very anterior toward the anterior lobe. It's actually in a perfect position.
Okay, so we're going to go ahead and take out the pigtail now.
So, of the complications that can occur with this procedure, it's a large guiding catheter, so you've got to be absolutely meticulous about flushing technique so you don't introduce air into the system. That is something people have to be comfortable with. If you've done mitral clips and other procedures like this, I think you already know. But the other, of course, is that, this is a relatively stiff catheter, and the left atrial appendage is extremely thin wall, friable, so you have to always know where the tip of this catheter is.
So you can see the marker on the delivery catheter coming to the end of the sheath. And what we're going to do is we're going to line up these 2 markers here at the tip.
Looks like the sheath is in some tuberculates, sort of holding contrast.
Right, so that's it, right? And now we're going to slide the delivery sheath back and lock these 2 catheters in place. And now we're going to loosen this bar, controls the device. So now at this point, we're going to start pulling back on the delivery system. Very slowly. This is not something that needs to be rushed. The slower you do it, the more controlled it is.
So he's exposing the device and pulling back both the delivery catheter and the sheath together.
Correct. You can see the feet starting to spread. And it's going to pop open here in a second. Okay. Okay, now what you see here, and Becky will show us this on the echo in a second, but you can see how the distal feet are all still compressed. And that's going to leave you with a device that's not fully open to its full diameter. Now, sometimes if you use a large enough device, that's not a problem. But if you need this thing to open up fully, and we're going to look at the echo now in a second, we may need to redeploy this a millimeter or so more proximate. Becky, why don't you see what this looks like?
Yeah, so here's the device, and you can see the feet. I'm using the pointer all the way down here. Again, it seems pretty compressed. And then the position, however, is pretty nice as far as the depth into the appendage. And so obviously it's a risk-benefit to reposition because sorry about that, because the position itself is actually quite ideal.
Okay, so what we need to do, since it's not fully expanded, is just make sure there's no gaps around the device. So Becky will look for flow.
Sorry. Get a little bit of that.
photography doesn't look too bad. And with this device, unlike the ACP device, you can only redeploy this in a more proximal position because you don't want to re-advance the device into the appendage, leading with those legs or spears, as we affectionately call them. So you can redeploy this proximally if you like, but once you're too proximal, then you have to take it out and start again. It's got a little leak, right?
Yeah, a little leak.
Okay, so I think we're going to just try redeploying it in position and then... Okay, so this is now quite simple to recapture. It's just, if you think of like an Amplatzer device, it just folds back up inside the sheath.
That display looked like it opened a little bit already right now, sir.
But you don't want to... now, sometimes just that maneuver will open up the feed a little bit, so you can just redeploy it right at the same spot.
Store that?
Yeah, it's a little further out, which is good.
And I think that looks better.
Much.
So we didn't... Yeah.
Here, I'm going to play, I think we got that, but you can see, just as Bob started to recapture, even before he fully recaptured, the distal feet sort of open. Not yet, but very shortly after this point. Right there, they open more.
Now, in the Watchman trial, it was considered to be closed when in the Protect AF trial for a leak less than 5 millimeters. Clearly here we have perhaps a 1 millimeter leak near the pulmonary vein, but there's obviously no big leaks here. But we leave this up to the echo folks to sort of help us with this. We're pretty proximal here. You can see the coronary artery there. We don't want to be too much more proximal than that.
So you saw these little tiny leaks, very small.
Okay, so now what we're going to do is a little tug test. So we're just going to pull the sheath back a little bit, and we're just going to tug on this. You can see the motion here.
If you look on echo, you can see the appendage moving with that.
Right, and so it's not going anywhere. It's in there pretty well. I don't think it's shifted position substantially.
Nope.
So this device is
And
retained...
now we can take a picture.
Both, based upon correct sizing and the radial compressive forces, and there are multiple tines and little hooks that connect it to the appendage.
Right, and the other important point here is that we need to measure the compression of the device to make sure that it's going to be stable. We need to compress the device from its baseline of 30 millimeters to about 8 to 22% is the recommended compression. Over compressing the device, we think that you end up with gaps around the fabric of the device, and under compressing the device may not be stable. So, okay. So we're going to do a little injection here on the fluoroscopy. Jack. So this looks really nice. You can see when there's a big leak, since we're so close to the face of the device, you'll fill up the whole appendage with contrast. Here, there's just a very trivial filling. You can see some of the dye hangs up inside of the device. So this looks pretty good angiographically. And now Dr. Hahn is going to confirm our compression numbers. And then we can go ahead and release the device.
The other issue while Becky's getting those numbers that came up clinically in this patient is she's young, and there was a discussion about doing a the ablation for her atrial fibrillation. And some of the ablation points are near the left atrial appendage, and there was an extensive discussion about whether to do the ablation first or the closure first or same setting. The issue with doing the ablation first is there's a likelihood of needing to do a repeat, and it would take 3 to 6 months to verify, and the bleeding risk was felt to be high. So understand that it may not be ideal, and at some of the points that they would typically ablate, which are near the appendage or a little bit into the appendage, they may not be able to do with this device. The decision was made to close the appendage first and try and get her off Coumadin as soon as possible.
You good, Beck?
Yeah, it's
Okay. All right, so we're pretty happy with this. Apparently, we're not going back to the other room.
No, we're not.
So we're
but
going to
we
go
have
ahead and release this.
Okay, as you're releasing it, we have a question from yes, from Dr. Mangione and Carlos Pedro.
Just a brief question, Susheel. How long do you keep this patient on oral anticoagulation after the procedure? For how long?
So the original...
just a quick question regarding indication. Are you doing cases only with contraindication to anticoagulation or also as an option to anticoagulation?
Yeah, so, okay, those are both excellent questions. The original Protect AF trial required a 45-day course of warfarin after the implant. And we're pretty much sticking to that, except for the patients who can't take warfarin at all, in which case we're typically using dual antiplatelet therapy. At 45 days, a repeat transesophageal echo is performed, and the patients will, if there's no significant leak, the warfarin can be discontinued at that time. The protocol then called for dual antiplatelet therapy for 6 months, and then aspirin therapy indefinitely. So that's what we're doing with the anticoagulation. We have a little more flexibility now that this is approved in the United States. It's an off protocol, so we have some flexibility to manage patients who have warfarin contraindications. And so, you know, I think what we do in those patients is we weigh the risks and benefits of the 45 days worth of no anticoagulation after implantation of the device. So there is some thrombotic risk potentially. And we weigh that risk against the long-term risk of not being able to take warfarin with a high CHAD score. And I think most of the time we end up deciding to close the appendage in those patients. So I think, you know, these strategies are evolving. You guys have been doing this around the world for longer than we have. We got held up significantly by the FDA and then eventually by our government payers who was evaluating this. So we've really only started doing this in earnest this year.
Hey, Bob, quick question. Because we are just starting with experience with the Watchman device here in South America, I think Ricardo Quispe from Ecuador, he has a fair amount of experience. He's been proctoring us. So why don't you go ahead and make some comments with regards to indications and limitations as to the depth of the left atrial appendage, right, maximal diameter, maximal size of device, yeah, etc.
Okay. So the maximum size of this device is 33 millimeters. And then on top of that, you need about a 10% at least compression. So no, you can't have an appendage with an ostium more than 30 millimeters unless it has tremendous depth, in which case you can seat the device a little bit further into the appendage. I like to think of this like an ice cream cone, right? You can put the ice cream scoop all the way on the top of the cone, or you could put a smaller scoop inside the cone, and it'll sit down further, but it will still occlude the distal portion of the appendage, which is where most of the thrombotic complications occur.
And it's the 30 in the largest dimension, not
right,
not
30
average.
in the largest dimension. So for us, that's really the rate-limiting step. We've seen one patient anatomically who had like a bifid atrial appendage where a tissue rim came up almost all the way to the ostium with two separate lobes, and so there was really no place to put the device. You didn't want to put it into one lobe or the other, so that patient we elected not to do. As far as indications go, we're focusing primarily on a few groups of patients. The first one are patients who are warfarin ineligible. I think that's an excellent group to think about this procedure, who have high CHAD scores. The second group of patients that we're focusing on now are patients who have had bleeds or other problems with anticoagulation but aren't necessarily contraindicated, just high risk. The third group that we're really interested in now, and we're looking to start a registry here at Columbia, is a group of patients who are on triple therapy, patients who have atherosclerotic disease, who need drug-eluting stents, and who then would have to be on triple therapy and super high risk of bleeding. And those patients may really benefit from being getting the Watchman device and coming off of the oral anticoagulant while they remain on their antiplatelet therapy.
And the other group is, sort of from the valve center perspective, is the patients that we do TAVR on, about 30 to 40% have AFib. And all of them are in general higher risk for bleeding. So we've also talked about, engaging that group and potentially saying, I know centers around the world are doing same setting. There's obviously issues with that, anticoagulation, reimbursement, and other issues as well, but that's another group that probably is a large potential population that we have here as well.
But this was a great case example. It's a wonderful lead-in to this structural session that we're part of. Unfortunately, because of time constraints, we're going to have to leave you right now. We're going to wish our coronary colleagues well. We're not going to be able to go back to their room, unfortunately. And we'll find out what the results of that CTO were. But this is really a beautiful demonstration of a new technology that, at least we believe, is going to have important implications to a wide range of patients with atrial fibrillation in the future. So from us down in Brazil, SOLACI, we want to thank Bob, Susheel, Becky, Juan, and the Columbia team for showing us this beautiful case. Thank you.
Thanks so much.
Thanks, everybody. Have a good meeting.
Thank you. Take care.